All right, folks, it does look like we got our live stream all set up. Thank you all for being here this, I guess it's afternoon for both Central and Eastern time zones now. So good afternoon to everybody. Today, we're going to have a really special presentation on the social determinants of health from two of my colleagues at Shatterproof. As always, I'm going to roll through a little bit of housekeeping items. We're going to give a brief overview of the UNSHAME Kentucky campaign and then dive on into that presentation. If you have any questions about technical, if you need some technical assistance, any questions about UNSHAME that pop into your head throughout the presentation, please feel free to use the chat and you can send me a direct message and we'll be happy to answer questions throughout. Like I said, a few housekeeping items. If you all could please set your view to gallery. This will allow you to see both the individual who is speaking and our interpreters at the time as they remain spotlighted throughout the presentation. Like I said, we're going to roll through the housekeeping, a little bit about UNSHAME, and then we'll get to our presentation. Our campaign overview. For those of you that this is your first webinar, we're going to explain that UNSHAME Kentucky is a 12-month evidence-based behavior change intervention. We are really here to talk about stigma. We want to talk about what are those barriers between someone who is struggling with SUD and receiving treatment. The campaign is delivered by Shatterproof. Shatterproof is a national nonprofit, and we are in partnership with the Kentucky Opioid Response Effort, or CORE, and our program is funded through a SAMHSA grant. The goals of our campaign are to increase knowledge of those in Kentucky and really give the message that recovery is not only possible, but probable with proper support. We want to improve the attitudes of the residents of Kentucky towards those that are still struggling with SUD. We want someone to interact with a loved one or interact with a stranger who's struggling in a positive way and look at the light at the end of the tunnel as someone can begin a recovery journey. How do we encourage people to do that? And we want to better develop Kentuckians' understandings of the disease. We want people to be able to understand that addiction is not a choice, but a disease, that substance use disorder is a treatable illness. We do this through three main pillars in our approach. Our community connection, which is working with the community-based organizations, getting those needs assessments, those folks who are already in Kentucky doing so much great work. They are our guides throughout the process, tell us where the stigma lies, what communities need the biggest impact, and help us maintain focus in those areas throughout our campaign. We also collect stories and testimonials of those in recovery, those who work in treatment, and those who have been affected by the disease, maybe through a loved one. And that's a really important part of our campaign. This really helps put a face to the disease, helps grow that understanding that this disease can be anywhere in our communities. It could be our brothers, our sisters, our parents, our preachers, coworkers, school teachers. You know, getting the perspective from as many people as possible has proven to be a real cornerstone of our campaign. And then we also have our educational piece, which is something that we're doing right now, hosting webinars, putting out our targeted messaging to provide education not only to community-based partners to learn maybe new skills, but also to the community so that they can take these skills and apply them not to a business, but to their personal lives. I'm now going to get Jody and Megan on to move forward with their presentation.
Thanks so much, Chapin. All right, everybody. It's really a pleasure to be here with all of you and some of my other Shatterproof colleagues today to spend some time talking about the social determinants of health, the social determinants of opioid use disorder, and a bit about health equity and how this all relates to the work that hopefully you all are doing in Kentucky, certainly, and what we do at Shatterproof. So I'm Megan Halmo. I'm the director for healthcare with the National Stigma Initiative at Shatterproof. I'm going to kick it over to my colleague Jody to introduce herself as well.
Good afternoon, everyone. I am Jody McIntosh, and I am one of our directors of community engagement on the National Stigma Initiative at Shatterproof. And I would like to echo Megan's sentiment. Very excited to be here today and to get into this discussion.
Thanks, Jody. So today, again, the title of this webinar is Against Moral Failing, the Social Determinants of OUD. We are going to touch a fair bit on health equity in addition to social determinants of health. And what we really want you to take out of today's webinar are the following things. So I want you to be able to define or identify the 6 categories of social determinants of health. Some people say there's, more categories. Some people say there's less, sort of up for debate, but, there's 6 pretty well agreed upon categories for SDOH, which you'll hear us call social determinants of health here and there. Understand OUD related inequities and other health equity issues and inequity issues and how they relate to opioid use disorder and how social determinants of health relate to those. And then just get familiar with some resources that you can visit if you want to learn more about social determinants of health, health equity, health inequity, health disparities, and again, specifically as they relate to opioid use disorder and specifically as they relate to what is going on in Kentucky. Now, I will say before we jump into the webinar that Jody and I are not experts in Kentucky, in the landscape there in Kentucky. And so we're really going to be talking mostly about social determinants of health and health equity as concepts more broadly. And so, you all are the experts and we'll invite you to jump in with anything that, feels relevant and important to share in the chat when it comes to Kentucky specifically. So please feel free to do that, and just want to make sure that we give that caveat here. All right. Thanks, Jody. So in a couple of places here, we are going to ask you to interact with us if you can. We are going to, in a few places, give you about a minute to answer a question, and we'll ask you to put those answers in the chat as they come up. There's no right or wrong answers. I'll tell you that right now. We're just gonna ask for folks to sort of give us a sense of how they're thinking about some of these issues. In the Q&A box, as questions come up for you throughout the webinar, please go ahead and put those in the Q&A box. We'll come back to those at the end of the webinar with the time that we have left. And again, any other specific thoughts that you have on Kentucky, especially to help us sort of contextualize this a bit more, please feel free to share those in the chat. We also are going to do some polling during the webinar via Mentimeter at menti.com. So if you want to jump into menti.com right now, feel free, but we'll give you all the information in a minute. Okay, so we're going to share here with you a little vignette of Sam. Sam, we're going to sort of talk about him here and then come back to him at the end of the webinar just to bring some of these social determinants of health issues and other pieces to life here. So Sam is a 35-year-old white male. He lives alone in Pikeville, Kentucky. He grew up in a Christian household, and he does still attend church with his mom and his grandparents when he can. He graduated high school. He's pretty tech literate. He spends a lot of time watching and sharing his favorite music videos and other hot takes, like the kids say, online. Sam started an associate's degree program, but after 2 semesters, found himself pretty deep in debt and couldn't really continue justifying the tuition. He did lose his brother to a car accident around the same time and found it hard to focus at school. When he's not working as a long haul trucker or on the road for a long job, he likes to go fishing with his friends that he grew up with. He loves live music, but rarely finds time or energy to make the long trek to the city for shows. He does have an opioid use disorder, and that started about 4 years ago after he was prescribed pain medication for a back injury he got while loading his truck. So this is going to be our first opportunity for interaction. I'd like everybody to take 60 seconds and hop into the chat and tell us what you think might contribute to Sam's opioid use disorder and his ability to get the help that he needs. And I'm going to time us at 60 seconds.
So Megan, I was just informed that the chat seems to be disabled. So while we're figuring that out, maybe we can just use the Q&A function. If you all just drop your thoughts in the Q&A function. I did see that somebody used that already to answer this question that's presented on the screen.
Perfect. Thanks for putting that out, Jody. So if everybody could jump into the Q&A function.
Great, we see those answers rolling in. Time check, Megan.
10 seconds.
All right.
All right. Thanks, everybody. Thank you so much for participating. You can see we have an active group today, so that's really, really exciting. We are going to come back to some of your answers. Jody is going to be sort of pulling together some of the themes that we're seeing in that chat. We're going to come back to this at the end of the webinar. So just to start off here, so some terminology. Health disparities. What are health disparities? Health disparities are a difference in health outcome. This is just an observed difference in a health outcome between 2 groups of people. And we don't know what the cause of it, that difference in health outcome is. Health inequity is kind of like a health disparity. So it's a difference in health outcome. But it usually reflects some form of injustice, meaning maybe resources or something was sort of happening unfairly there that caused that difference in health outcomes between 2 groups. Health equity, well, it seems like it would, pretty obviously be the difference in or the opposite of health inequity, but really that is the state where people have a fair and just opportunity to attain their highest level of health, okay? And then social determinants of health, I'm actually going to hold on this one because we're going to come back to it in a moment. But these terms, health disparity, health inequity, and health equity, can really get thrown in the conversation a lot with social determinants of health. So we want to make sure that folks have a good sense of what those are. So if we go to the next slide, we're going to see a useful image that can also help us to understand the difference between 2 terms that get confused a lot, understandably. So equality and equity. Equality is the state where everybody gets the same thing, regardless of whether that thing is what's needed or is right for them. Equity, on the other hand, is where everyone gets what they need, understanding the unique barriers, circumstances, and other conditions that people are living in. And so you can see here in the image that we've got several people, and each of them need to cross the street. But if everybody gets what they need, the same thing, I should say, then, you know, they got to step down the curb and get across the street. And some people are able to do that and some aren't. In the image to the right there, you can see that everybody is sort of getting a different set of services, or different things are happening there for them to be able to get down that curb safely and get across the street safely. And so if we all get the same thing, then we're all not going to be able to cross the street. And it's pretty important that we understand that when we're distinguishing between a state of equity and a state of equality. And I will say this particular image comes from the Robert Wood Johnson Foundation. They actually have several images that they use to help define the difference between equity and equality. And this is just a quote from the former CEO of the Robert Wood Johnson Foundation, actually, Risa Levizo-Murray, and her, and she said that health in the US is really a tale of two starkly different realities. So the better off and well-connected are not only in a stronger position to receive care when they need it, but importantly, they start off with advantages that have a tremendous effect on health from the beginning. So those advantages come in housing, employment, stress levels, food security, social capital, and more. So really want to highlight that piece that talks about when they need care, sure, they can probably get it more easily than somebody else. The likelihood that they need that care or the same level of care of somebody else who doesn't have the same advantages probably isn't, again, even as likely, because they've started off in a completely different place than other groups of people that cause them to likely have better health to begin with. So very important to understand that. So social determinants of health, what are they? Social determinants of health are the conditions and environments where we're born, where we continue to live, where we learn, work, play, where we worship, where we get older. And they affect a wide range of health, functioning, and quality of life outcomes and risks. And so you can see here the 6 mostly agreed upon categories of social determinants of health. And some sort of smaller categories that fall in underneath each of those. So economic stability, neighborhood and physical environment, education, food, community safety and social context, and the healthcare system. So of course, there are a lot of other sort of smaller conditions that come in under each of these categories, but these are really like some sort of broad areas that we can start to think about. Oh my gosh, what is happening in each of these areas that affects our health? Other things that would come into this, for example, are immigration status can affect our health and our ability to access care or want to seek care, even to start off with. The type of job that we have. Stress, of course, is in here, but it's caused by so many things and causes so many things, has an incredible impact on our health. And that is considered, along with all of these other things, a social determinant of health. So we're going to give you a chance here to jump in with a poll. And Jody will just we're gonna hold on one second. I'm getting to it. Thanks, Jody. Jody's taking on all of the slide navigation today. So thanking her in advance because she is much better at the internet than I am and technology. So we're gonna ask all of you to go to www.menti.com and enter the code you see there. I'm gonna give 60 seconds once again. When you enter that code, you're going to get a couple of fields. We'll ask which 2 categories of social determinants of health do you think affect opioid use disorder specifically the most? And you see the codes or the categories, excuse me, up there. So giving you about 50 seconds. No right or wrong answer. How's it going, Jody?
It's looking good. It's looking good.
Great. 10 more seconds.
Okay.
We've got some
gonna-
people coming into the chat too with some answers, which is great.
Yeah, and those who are participating, they can probably see the how the mentee is changing over time.
Great.
And
Excellent. So can we share that mentee screen, Jody, or the folks that are in it can see it?
they can see it, but I'll share it. So it's still, you can see that it's still going.
Cool.
But
Great.
you can kind of see the main ones here in the middle.
Excellent. So it sounds like a lot of people have come in with the healthcare system or healthcare, economic stability, neighborhood, healthcare. Yeah, I see healthcare a lot for sure. Education, interestingly, community, economic stability. Absolutely. Okay. So, I mean, I think what we can see here is everything, a lot of them are coming up.
Mhm.
And the truth of the matter is all of these things do probably maybe equally even affect opioid use disorder and ability of folks to seek the care they need. So thank you for participating in that. That's a really cool way of visualizing what the group thinks. So let's touch sort of again back on those social determinants of health, and this is a slide with a lot of small text here, but hopefully you can see it. This is a really nice framework for understanding health equity or health inequities. And you can see at the top that there's this arrow that starts at upstream all the way to the left and goes to downstream. And when we think about social determinants of health specifically, we're often talking about conditions that are happening further upstream. And those conditions, if we address them, can help prevent opioid use disorder or help people to access the care they need for opioid use disorder or other health conditions earlier. And again, within those, within that oval, or circle that you see there, you're going to see similar themes to what we just pulled out, those 6 categories that we just pulled out, but social inequities, along the lines of class, race, ethnicity, gender. Institutional inequities come through in law, policies and regulations in government agencies, laws, what non-for-profit organizations, what they're funded to address, for example. Living conditions, again, that's a lot of housing, education, healthcare, social services, et cetera. And so all of those affect the things that we see coming in more downstream, like risk behaviors and disease and injury. And so a lot of times we come in at risk behaviors, you're like, oh, we got to help the person, do something different, and then everything will be fine. And we ignore all of the stuff that's happening further upstream that even, help them to arrive to that risk behavior or something that they needed to do or ended up doing for any number of reasons, right? And that don't depend on who they are as a person, what kind of what sort of exists within them, right? It's all stuff that is social determinants of their health. All right. And so just another way of visualizing this, if we move on to the next slide, is an actual stream. People like to, just throw an actual stream up there and visualize sort of where they come in the public health process. Is a very popular image in public health. So you can see some examples of strategies and then tactics to address those strategies in the stream image here. But really we're looking at, things like improving community conditions come in upstream. When we get further into the middle of the stream, it's addressing an individual's social needs, providing clinical care is downstream. Those would be medical interventions, et cetera. And then we're talking specifically about, if you want to move to the next slide, Jody, the root causes of health inequities and overdose and OUD related to social determinants of health. We can continue to sort of see like some of the things that come in the stream and where. So issues that are way upstream are like a person's class or race, ethnicity, immigration status, law and regulation, which we saw in that inequities image with all of the text on it, coming in also upstream, those social determinants of health, things that we might address upstream, whereas downstream is where we're again really coming in with medical interventions to address things like comorbidities or polysubstance use or actual behaviors, etc. So we wanted to ask, and Jody, do we want to do this in Mentimeter again, do you think?
Completely up to you.
Yeah, just looking at time, so I want to make sure we have it, but I think we can go ahead and go back into Mentimeter, enter this new code, and just ask, where do you spend most of your time? Either working, if you're working in the field specifically, or where do you spend your time like thinking about the most when it comes to social determinants of health and opioid use disorder? Upstream, midstream, or downstream? Where are you? It'll take about 40 seconds.
So far, midstream is leading with most of the votes. Upstream is second, and downstream is third. It seems to be holding steady there.
Yeah. Excellent. Yeah, harm reduction, peer support, wherever that falls, is probably a bit of mid and downstream, I would think. Yeah, great. Well, thank you all for participating in that one. We're going to ask you to do one more, and that is, if you could just have like your dream fully funded program, didn't have to worry about money at all. You could throw all of that effort and all of that money into one place in the stream, where would you put it into? And I know this oversimplifies things a bit, but upstream, midstream, downstream, and there's your new Menti code to vote, or put it in the chat. Midstream in an upstream institution, yeah. Great. We'll do about 20 seconds here at most, because I think people are pretty fast.
So for those who aren't voting on the Menti, and also for you, Megan, it's looking like midstream and upstream we're kind of going like back and forth leading. But right now it's looking like midstream has the lead.
Awesome, interesting. So it's really cool to see that, or hear that. It sounds like a lot of the people here with us on this webinar are working in those up and midstream places, and really you're working on the social determinants of opioid use disorder, the social determinants of health. Yeah, that quote that was just put in the chat, I forget what it was, but a penny for 18 cents or $18 or something. It can be harder to see it on the day-to-day basis, but when you're putting that time and that effort into those upstream pieces, even though it's harder to feel like you can draw that direct line and say I did this and it happened, can make a really big difference in health outcomes downstream, including when it comes to opioid use disorder and care access. So with that, I am going to kick it over to Jody to keep us moving. Thanks for everyone for your participation in this first part.
Yes, thank you all. So Megan has kind of laid the foundation for us with defining social determinants of health and equity, and kind of starting to imagine how that plays out within OUD. The next few slides, we're going to talk a little bit more about the actual ways that we've seen social determinants of health show up over time in both OUD, OUD and treatment and response. And then we'll look at it from a larger level, like throughout the country, but we'll also focus in a little bit on Kentucky specifically. So I know this is small text, but this presentation will be available to everyone at the end of So for some people, there might not be an awareness that the opioid epidemic didn't just start 10 years ago, 5 years ago, 3 years ago. It's actually been an ongoing concern in the United States. And I'm speaking specifically to the United States that dates back as far as the Civil War. So back to the 19th century, when morphine was being used on the battlefield to treat wounds, and unfortunately leading to folks living with OUD. At the same time, we also saw that morphine, because there wasn't anything else available, it was heavily prescribed to people who could afford it. And in that case, in that time, it was white women for pretty much any ailment. Women were, going to their physicians and complaining of headaches, and they were getting morphine. Menstrual pains, they were getting morphine. So we started to see an uptick in the use of morphine, and again, an uptick in addiction amongst that population. Then in the 1860s, during the building of the Transcontinental Railroad, we saw a huge influx of Chinese immigration to work, the Chinese labor for that. And opium was used for remedies for work-related injuries. And so then we started to see opioid use or opium use being associated with Chinese immigration. On top of, some other factors, Chinese workers were seen as a threat, and we saw the Chinese Exclusion Acts, which were introduced, which pretty much excluded Chinese immigration as well as travel due to some of this like stigmatizing. And then here we're thinking of social determinants of health. So I've already described two different, if we want to call them employment tracks that would have impacted a person's access to opioids. So one was, being a soldier. Another was, in this case, being a railroad worker. Then in the late 1890s, we see the introduction of a quote unquote non-addictive wonder drug, which was really heroin. And it was supposed to be a safe alternative to morphine. And it was being used for children. It was being used for coughs. Once again, we're seeing a medicine being pretty much overprescribed and mismarketed to the populations. And so once again, we're seeing that opioid addiction, the face of it is looking a little different than it did, earlier on in the century. Then in 1914, the Harrison Act was passed, which pretty much put a tax on morphine and heroin, and it forced the doctors to register drugs with the government it forced folks to register drugs with the government to prevent doctors from overprescribing them. So there's like this initial acknowledgement like, oh snap, there might be an opioid problem and we need to do something about it before it kind of goes out of hand. And so that's what the Harrison Act kind of signifies in history. And then 10 years later, you have the Heroin Act, which prohibited the manufacture, importation, and possession of heroin, even for medicinal use. And then we're fast forwarding 20 years, and I know I'm going through big chunks of time. There really is so much that we can talk about when it comes to the history of opioid epidemic, but I thought it was important to just highlight the things that kind of relate to SDOH. So during World War II, heroin black market started to emerge. So remember, now heroin is illegal. And so that pretty much pushed it into the black market because people weren't able to get it from their doctors anymore. And At the same time, we see that there are pretty much parts of the country, and we're going to show kind of a map in a little bit, parts of the country where heroin is coming in and out, kind of like a drug trade, for lack of a better term, that are more greatly affected. And these parts are areas that are big cities, and areas that have largely low income and people of color. And so once again, we see another change in the face of addiction. So addiction is now, thought of as something that happens in the big city, and it happens to these certain types of people. And then in 1951, 11 years later, the Boggs Act was implemented. And this act, it imposed mandatory minimum criminal penalties and prison sentences. And this is where we kind of start to see that criminal justice involvement and how it really, changed the course of opioid addiction. When we think about social determinants of health, what that did to entire communities because of how opioid use was criminalized rather than treated at this particular time in history. And then in 1970s, the war on drugs begins. It's called America's Public Enemy #1. And for years, we just see a slew, like 30 years, a slew of different laws and policies that are enacted that are generally criminalizing substance use, and not so much effort being put into treatment. While this is happening in the 1980s, the HIV epidemic begins. And so now we have these two very stigmatized kind of conditions floating around in society. And you have people who don't understand, what HIV is, where it came from. And we're starting to stigmatize certain types of people. We're stigmatizing certain types of behaviors, including OUD, and there's a connection that begins to be made between the two in this risky behavior kind of category. But fortunately, we also see the introduction of harm reduction as an alternative to abstinence-only programming. And then in '95, the FDA approves OxyContin. And so this is another kind of turn in opioid history, where OxyContin was marketed as less addictive, it was going to be safe. It was very much pushed towards lots of healthcare providers and marketed to them to provide it to their patients, because it's supposed to be safer than all the other opioids that you might know of previously. And it was mainly pushed towards low and middle class white folks in the country. It was not necessarily something that doctors in low income urban areas were using. You see it more in the lower class white areas. And then in '99, so the next three are kind of talking about where we see rises in specific overdose deaths. So in '99, we see a rise in the prescription opioid overdose deaths. So just 4 years after OxyContin is introduced. In 2010, we see a rise in the heroin overdose deaths. And then in 2013, we see a rise in synthetic opioid overdose deaths. And that's things like fentanyl, et cetera. From 1999 to 2020, more than 564,000 people died from an overdose involving any opioid, including prescription and illicit opioids. And then in 2021 through now, we have the National Opioid Settlement, which pretty much provides funding to jurisdictions for abatement of the opioid epidemic. And these funds have been used to support and develop amazing programs throughout the country. And we hope that we can continue to see, specific efforts move towards addressing social determinants of health. So moving into some kind of specific categories, when we look at race and ethnicity as it relates to overdose deaths, the recent uptick disproportionately affects Black non-Hispanic folks in the country. Again, this is nationwide. And then we also see it's very, very high for the American Indian, Alaska Native, and non-Hispanic population. And then we see the white population thereafter, Hispanic, and then Asian and Pacific Islanders, kind of at the lower end of that spectrum. When we think about health insurance coverage, it's another kind of indicator of health or a social determinant of health. What we see, and I'll kind of explain the colors here. So for orange, we're looking at those who have Medicaid. That darker blue, kind of navy blue, is those who have private insurance. The regular blue is the other, and then the light blue is those who are uninsured. And so on the left, we see all non-elderly adults with opioid use disorder. So it's about 1.98 million people. About 38% of them have Medicaid, and 34% have private insurance, and 20% are uninsured. And then when we look at low-income adults with opioid use disorders, so that's 963,000 of those, we see that Medicaid number kind of goes up, where there's 55% who have Medicaid and only 13% have a private insurance, and 13 have other, and then 19% who are uninsured. And so, just take a couple moments to just kind of think about, well, what that means if we're thinking about, the title of this is against moral failing. So it's not just about, a person not having the will to get the treatment. When we think about just, health insurance, how does that really impact the type of care, or, if you are able to even get care to begin with? And so I'm going to play this video. There is no sound, but it really is a good kind of demonstration of treatment access across the country. And you'll notice that Kentucky is highlighted on here. But it kind of brings you through the areas with low or no access to buprenorphine, areas with the highest need, and then areas with a high need. So I'm going to go ahead and play that. It's about a minute. And so it's saying, where you live affects your access to medicine that treats opioid addiction. This medicine is called buprenorphine. And then here are the geographic areas in the United States with the highest need for buprenorphine treatment. And so again, the highest need areas are the dark green, and then areas with a high need are in that light green. And then it's asking what high need areas have low or no access to buprenorphine treatment at doctors' offices. So then this map is now overlaid with those that red outline. So you can kind of see a lot of correlation with that. 56% of these high need areas have low or no access to that type of treatment. And if you want to see more, you can, of course, visit this link here. Okay, so now we'll go specifically into talking about the social determinants of health in Kentucky. So we know about 16% of folks are living in poverty. 6% are uninsured, and 7% of the Black African American population are uninsured. 7% have zero-car households. There are about 93 primary care health professional shortage areas and 102 medically underserved areas. So that relates right back to kind of what we were just looking at on that map. They have an 88% high school graduation rate. And there are also high rates of comorbid health conditions. So pretty much having multiple health conditions. And it ranks more than 10 urbanization index, less than 10, excuse me. So when we look specifically at overdose in Kentucky, we have been seeing an upward trend. So in 2019, there were about 1,300 overdose deaths, and that number increased in 2020 to more than 1,900 overdose deaths. So that's about a 49% increase from 2019. And in 2021, there were 2,250 overdose deaths. So that's a 14.5% increase from 2020. Black individuals had the largest increase of overdose deaths by 34% from 2020 to 2021. And so the question is, well, why? Why are we seeing these kind of trends going up? We have all of these efforts that we have put out to address OUD, but we're still seeing trends going up. And there are two kind of key areas that we'll highlight today. Illicit fentanyl in the drug supply. So that's been involved in over 90% of all the overdose deaths in Kentucky and about 70% nationwide. And then the social determinants. So if we're thinking specifically over the past 3 years, COVID-19 led to greater isolation. There were economic stability concerns. So we're thinking about that economic piece. You know, folks, we had anxiety about the future, public health, sickness, and the ability to meet these kind of very basic needs. So taking all of this into consideration, we're gonna come back to Sam. And now the chat is working, so you all can kind of chime in. So just remembering who Sam was. So Sam is a 35-year-old white male who lives alone in Pikeville, Kentucky. He grew up in a Christian household and still attends church with his mom and grandparents when he can. He graduated high school and is pretty tech literate, spending plenty of time watching and sharing his favorite music videos and hot takes online. Sam started an associate's degree program, but after 2 semesters, found himself too deep in debt to continue justifying the tuition. He lost his brother to a car accident around the same time and found it hard to focus at school when not working or on the road as a long-haul trucker. Sam likes going fishing with childhood friends. Sam loves music, but rarely finds time or energy to make the long trek to Louisville for shows. Sam has an opioid use disorder, which started 4 years ago after he was prescribed pain medication for a back injury he got while loading his truck. So now we'll give you a few minutes in the chat to just type in what social determinants of health do you think might contribute to Sam's OUD and his ability to get the help he needs. And you can just drop those in the chat. Great question. Yeah, is there even treatment? Is there treatment available? Ability to afford treatment, yeah. Lorinda, there may be additional information for methadone. That's something that we can follow up on. Yep, income, limited personal and professional growth opportunities, grief, social isolation. So that's something that came up earlier. Can he take time off of work? Economic stability, still in isolation, yeah. The shame to seek treatment, yep. Money, economic isolation. So yeah, a lot of the things y'all are saying are relating back to his economic ability to get the treatment he needs, as well as you know, being in isolation. And we have this quote from the RAND Corporation, which does a lot of great work. It says, the root causes of opioid deaths are diverse across individuals. However, they share some common socioeconomic and public health themes. For example, lack of economic opportunity, which many of you mentioned just now and also earlier on, persistent physical pain, feelings of despair, helplessness, and untreated mental health issues in both the short and long term. Address those issues directly rather than focusing only on opioid analgesic agents as the cause of harm. And so just something to marinate on as we continue to do this work. There are opportunities for us to do our part to contribute. You know, when we think, many of you said that you are working in the midstream and also upstream, and we want to continue doing that. We want to continue to kind of, you know, the clinical services are vital in setting that foundation. And we know that we also need to think about those social determinants, you know, kind of in that bubble. And so there are ways that you can help, and that's through sharing. So the 3 ways would be: 1, sharing the Unshamed Kentucky content that we have on both Facebook and Instagram. You can find us at Unshamed KY. You can also share your story. And sharing your story is for people who are in recovery. It's for family and friends of folks in recovery. It's for people who are working in this field. It's for anyone who has been affected by OUD. And you can also share Unshamed Kentucky resources at unshamedky.org/resources. And of course, if you or someone you know needs help, you can visit findhelpnowky.org. And so lastly, we want to leave you with some additional resources for how you can learn more about health equity and social determinants of health. So the Prevention Institute has a health equity and prevention primer that is excellent. NACHO, which is the National Association of City and County Health Officials, has a web course on the roots of health inequity. Policy Link also has a health equity moving beyond health disparities. And then locally, the Kentucky Center for Economic Policy has the critical investments for a healthier Kentucky. I want to thank you all so much for participating today. We know this was a little bit different from previous webinars. If you have any questions at this time, feel free to drop them in the Q&A, and we'll be happy to answer. Megan, was there anything that you wanted to add as we close out?
No, I just wanted to, I mean, I think it was really cool actually to see when we talked about Sam at the beginning of the webinar, that this group who's here on this webinar really already is you know, attuned to social determinants of health. And that's because I'm sure y'all are seeing it every day. And so hopefully, you know, we were able to just provide a little bit more sort of context on social determinants of health and how that relates to health equity and inequities and the complicated way that these pieces just come into our everyday life. And I was picked out one of the answers that was given in the chat when we were looking at Sam the second time, and it was, can he take time off work without losing his job? And it's just such a great example of how you can follow a social determinant sort of from the downstream all the way up. And well, if he can't take time off work, you know, because without losing his job, well, man, if he needs to grieve the loss of his brother, but he has to like go on the road and be isolated for for weeks at a time, that's going to be really, really hard. And then why can't he take that time off work? Well, maybe his employer doesn't provide that kind of benefit. So that's an organizational or an institutional issue, which is really a good example of an upstream social determinant of health. And then even further upstream than that, well, does the state of Kentucky have any regulations for employers? Are they required to provide a certain amount of family leave or leave for trauma or loss, like some other states are. Where I live in Massachusetts, you get, the state requires that employers provide some of these things, but in other states, not so much. And that becomes an equity issue because people in some states get some of these benefits and some don't. So you can just follow it all the way upstream. I could talk forever about it, but really, really impressed by, the contribution of this group in the chat, and thankful that you all joined us today to talk about this.
I'll turn it back over to Chapin.
Thank you, Jody. And thank you, Jody and Megan, for excellent presentation and discussion today. Definitely a lot. We saw a lot more activity today in the chat than we have. And I think that speaks to the value of this topic. If this topic is one that, either was new to you and you want to learn more about, or something that, if you've connected with some colleagues here today that you want to further this discussion with, we encourage you to do that. I'm going to share my screen one more time with just my contact information. If you have any questions about the presentation today, if you want access to more resources, you can email unshameky@shatterproof.org. That will be forwarded to me, and I'll be able to set you up with that. Like Jody mentioned, there are so many ways which we can continue to do this work, including sharing your story or signing up to be a community partner. And both those can be found on our website. I just want to give one last call for any questions to drop in the chat. And if not, then we will wrap up. And I see all the thank yous rolling in. How do we sign in? So you do not have to sign in to unshamekentucky.com, or I'm sorry, unshameky.org. You'll go to our resources tab and these will be found there. So Megan, Jody, thank you very much for lending your expertise for this afternoon. Thank you to our interpreters and our closed captioning. And thank you to everybody for participating today. And if you have questions about CE hours or certifications, you can email me at unshameky@shatterproof.org. All right, y'all have a great afternoon.